Welcome, everybody. It's wonderful to be back. Webinar number 1, season 3. It gives me great pleasure to moderate this with Ramesh Kekunnaya. Ramesh, how have you been? I have missed you and I have missed doing these webinars.
Absolutely, Ken. Absolutely. It's been a long time to connect with the world.
So today's webinar is the great debate, management of strabismus in children with developmental delay. To operate or not. And I think you'll find that the faculty that we have, the discussants, the speakers, are really going to bring a unique perspective, their own unique perspective, so that we can have a full and frank discussion. So have a look at our speakers. We'll introduce them more formally, but you can see that they're from all over the world. And of course, as part of WSPOS, that's how we work. We're a global village. And we're really, really glad to be back. It's 2022 is definitely going to be a superb year for everybody. And we thank you for participating in these webinars. So I'm going to kick off first, and then Ramesh, I'll introduce you to introduce the other speakers and discussants. Marcia Tabuse is an MD, PhD, an amazing person, a volunteer professor at UNIFESP, President of Ophthalmology in the Pediatric Society of Sao Paulo, Brazil. Marcia, welcome. Kyle Arnoldi is Assistant Professor, University of Buffalo, USA, Editor-in-Chief of the Journal of Binocular Vision and Motility. We have some news about that journal and WSPOS. And she's also Deputy President of the IOA. Welcome, Kyle. Beth Ramella is an exceptional human being. She's a CVI specialist at the Overbrook School for Blind in Philadelphia. She used to be in Pittsburgh. We were sorry to lose her. She's in the USA, and she's a teacher for the visually impaired. Well, what can I say about Ramesh Kekunnaya? He's now, congratulations, Ramesh, you've been given a new, even more responsibility. He's Network Director, Capacity Building for External Organizations, Director, the Child Sight Institute and the Technology of Innovation, and the head of the Just TV Ramanama Children's Eye Center, all at the LV Prasad Eye Institute. Ramesh?
Thank you, Ken. Again, I'm going to introduce some other speakers and moderators. Mauro Goldschmidt, he's from Brazil. He's the president and founder of Strabismus Institute, one of the fine institute in Sao Paulo. And Mauro is a fantastic strabismus expert, and he's a world leader in strabismus. Any strabismus webinar or any meeting is incomplete without an orthoptist. Daisy Gotts is a fantastic orthoptist, and she's a chief orthoptist from Antwerp University Hospital, Belgium. She is also on the WSPOS Executive and Scientific Bureau member, and she's also a council member of IOA. Welcome, Daisy. It's always a pleasure to introduce my friend, David Granet. He is a professor and vice chair of Shiley Eye Institute, UCSD, San Diego, USA. You will all know that he is a fantastic orator, any meetings, and he grabs the attention. And he's also the reason for this kind of education forum. Along with Ken, he's a co-founder of WSPOS, and he's also a co-founder of Pediatric Listserv, which most of us are enjoying for the last 2.5 decades. Welcome, David. And it's always a pleasure to introduce one more of my friend, Ken Nischal. He is also one of the reasons for these kind of webinars. We have a long association. It's always fantastic to work with Ken. He's a professor of UPMC Children's Hospital, Pittsburgh. It's always enjoyable, Ken. And finally, I would like to introduce my friend Paolo Nucci from Italy. He is a full professor of ophthalmology at University of Milan. He also conducted one of the fantastic WSPOS conference at Milan. Most of you would have come there. We would be soon there in the physical WSPOS conference. And he's also past president of Italian Society of Pediatric Ophthalmology. Very warm welcome to all of you. Thank you for participating.
Thank you. Before I talk about membership benefits and the two really big ones, what I love about these webinars is the people who are listening from around the world, and they love having their countries shouted out. So Egypt, Jakarta, which is Indonesia, Peru, India, USA, Brazil, Russia, UK, Ireland, Greece, South Africa, Malaysia, Thailand, and Singapore. So far, so good. Welcome, everybody, and thank you for being up. So, WSPOS is free membership, but we have two really important new membership benefits. If you're a member of WSPOS, Karga and WSPOS have signed an agreement that for their journal, Ophthalmic Research, which has an impact factor of 1.89, I think, the article processing charge is significantly reduced for WSPOS members. And another thing that, and I'm glad Kyle's on board, I'm delighted to tell you that if you are a member of WSPOS, you will have access to the Journal of Binocular Vision and Ocular Motility, one issue for free per year. And JBVOM have agreed to publish the Strabismus keynote lectures that were given at the World Congress of Pediatric Ophthalmology and Strabismus since it started in 2009. So Kyle, thank you very much for making that happen with us. And remember, free membership, and you're getting free access to journals, and you're getting reduced article processing charges. I'm going to hand it back to you, Ramesh, now.
Thank you, Ken. I just had two more housekeeping announcements. If you have any questions, please put them on YouTube comment section. We will ask that questions for you, and we will get that answers for you. And also, can I have the next slide?
Oh, sorry.
If you need attendance or participation certificate, please send an email to program@wspos.org. You will receive the participation certificate for this webinar. Next one. If some of the questions are not answered today during the session, because there could be so many questions, we will respond them to you and via email. Please write to admin@wspos.org. So if the repetition of this is required, we can always put it on the YouTube, so that whatever questions you have, I think the participation from the delegates is very, very important. Without any further delay in dealing with children of strabismus with developmental delay, I would like to invite Paolo to talk about I do operate, but I do not do early surgery. Over to you, Paolo.
Thank you. Thank you, Ramesh. You forgot to say that I'm a professional sailor also. But above all, as you said, 10 years ago, I was the organizer of the second World Congress of the Pediatric Ophthalmology of this society. And it's still a wonderful memory, as this picture says. And for this, I always thank Ken and Dave. According to the majority of the pediatric ophthalmologists, strabismus associated with developmentally delayed children should be considered separately, as there is a higher degree of unpredictability in terms of surgical response. I choose the title to clarify from the beginning my attitude toward management of strabismus in this group of patients. Can this move? Yes. These are conditions in which there is no uniform responses, no golden rules, because the strabismus can behave variably with respect to type of deviation, binocular vision potential, severity of the form, stability of the angle, also environmental influence, compliance of the child, and parental comprehension of the treatment aims, and finally, also the ophthalmologist's attitude toward this group of patients. We can say that no axioms and no best practice in this setting. One can only share personal experience. Certainly, the most challenging aspect is related to the so-called pushers. And in using this strong term, I include all the people involved in various ways in the education, social integration, and rehabilitation of these children. In other words, parents seriously interested in creating the best possible condition to include the child in normal social life. Teachers, they seek for help for improving their intellectual abilities, maybe over-evaluating the relevance of strabismus in obtaining better school results. And finally, the rehab team that specularly expects improvement of their motor competence after surgery. How realistic are these expectations after surgery? So we have 3 points important. Cosmetic alignment always carries a certain level of increased social integration. So for this reason, I'm quite pro-surgery, reporting that any cosmetic improvement offers much more than an aesthetical advantage. The second point is the true possibility to achieve an anomalous correspondence is always better than no correspondence at all, but I never had the impression of improved intellectual behavior, neither at school or with respect to better performance during our examination. The third point is the most important. On the contrary, I have often witnessed an improvement in sport activities and a more challenging behavior after surgery. And this has been frequently confirmed by the parents, teachers, physiotherapists in my experience. But there are also cons, I would say questionable cons for me. Someone argues that they are difficult to measure. Nevertheless, I concur with Steve Archer that in 2018 editorial in JAPUS, he stated that in strabismus exists a legend of the dose-response curve. So I try to quote his words. He says, accuracy of preoperative deviation measurement upon which the amount of surgery is based may have less potential to improve surgical outcome than generally believed. The second point is the variability of the angle. In this setting, variability is rarely a function of the altered ACA ratio. It has more to do possibly with the intrinsic muscle tonus of these children, and this varies with time, and is the reason for delaying surgery in my experience. And definitely the choice of correcting the larger angle could not be the option, and this is something that we want to discuss with you. The third point is that it is really an obstacle, the fact that they often do not accept glasses. I really do not have proof for this. If we assume that visual acuity or alternance are relevant factors in achieving a better surgical results, these are conditions in which lack of compliance with glasses is relevant. And this is the second point that favors late surgery. Still, there are no other options, and the only choice remains prescribing glasses and push toward wearing them as much as possible. Surgery cannot be postponed forever. The fourth point, the last point, is someone advocates unstable results. But a 2008 PEDIG study in ophthalmology clearly stresses that even in infantile esotropia, only 20% of the operated children achieve stable alignment, and with time, surgical alignment can deteriorate. Did we decide to avoid surgery in infantile esotropia? So finally, let me share just my personal experience. And this is a slide that in which I collected all my experience with this group of children. I am excluding in this slide the CP children with or without CVI. You see that the percentage that I see is not the biggest one, but I don't want to talk about this because there are people with more experience than me. But what you see is that this is a very heterogeneous group, and no unifying theory can work because, as you can see in this table, I think that each specific condition has a particular response. In the red signed syndromes, they are syndromes with very often present isotropia. The green one, Engelmann and Cohen, very often they have exotropia. Fragile X could be in between. And you see that hypercorrection that is quite normal in Down syndrome can produce acceptable, very good results, while it's not the same for Williams, in which the hypercorrection is very rare, and very early you have good results, but later on they go to exo deviation. So just to conclude, here I want to stress the most important take-home message on my part. Refractive errors should be always corrected. We have to aim to a slight undercorrection, except in Down syndrome, because Down syndrome is more stable. Inform parents about possible early or late unsatisfactory alignment, and stress that surgery will slightly improve child's life, but please suggest to play the game. Thank you.
Thank you, Paolo, for that wonderful summary of CVI with cerebral palsy and without cerebral palsy, and some of the other reasons for developmental delay in children. I think that aspect is very, very important. I just had one question, and then Ken can take. There are 4 things you said in terms of children with development delay. Number 1 is difficult to measure. Number 2 is there is a variability in the strabismus. And number 3 is the refraction. And the 4th one is unpredictable results. Which one, according to you, is the most common reason for delaying surgery or not doing surgery?
I think the problem is related to the ophthalmologist attitude. If you have bad experience with late overcorrection, that is something that happens very often, you usually start with a defensive position, avoiding to approach this group of children. This was my experience at the very beginning of my practice. Then I started to evaluate each single condition, and now I do operate very early Down syndrome patients without any problem. I have not so good experience with Engelmann, even if there was an entire group publishing excellent results with Engelmann syndrome, because they, in my opinion, they go toward a recurrence of exotropia. And I have problem with Williams syndrome, or fetal alcohol syndrome. They go with time towards a worsening of the angle. At the beginning, they are quite straight, but they goes to exo. This is possibly related to a different tonus that they have. I don't think, and the experience of Daisy and Kyle could help me in understanding this. I think that this the tonus of these children that is wrong. It has nothing to do with accommodation, with convergence. It's just a kind of spastic condition.
Kyle, can you throw some light on the measurement and the variability in these children? Yeah, I think Paolo brought that issue of hypoaccommodation, how these things are important when we really consider these patients. Thank you.
Well, that's a good point. A number of these children do have hypoaccommodation, and I think more of us should really be evaluating accommodative ability in these children before we do surgery. Some of them are quite delayed and can't cooperate with the usual tests, but dynamic retinoscopy is something that can be done with minimal cooperation, really. It's true that the measurements can be quite variable, and I agree with Paolo that the variability seems to be unrelated to fixation distance. This is not an a variability that is due to incompetence or accommodation or any fixation distance, anything like this, even visual attention. Sometimes I do believe that it has a lot to do with muscle tone, and there are certain patterns. I discussed this a little bit in my talk. There are certain patterns that you can expect based on what type of developmental delay the child has.
So I'm going to interrupt there for a second. Mauro, Daisy, do you want to take up this issue of, we've talked about developmental delay, strabismus and developmental delay, but that's quite a heterogeneous term. What are you, how would you define this population that we're talking about? Because Paolo already has differentiated between cerebral palsy, CVI, and these other specific groups. Your thoughts? You're muted, Mauro.
Well, Ken, I really don't know if I have a definition for including all those types of conditions that Paolo mentioned, but every child that are not following the right way to learn and to get all the acquisitions for reading and for developing, they have some delay on their development. So it's not just a matter of having a syndrome, a name, but any condition that brings a delay in their development. So I'm not sure there is a way to define this set of patients.
I agree. Daisy?
Yeah, well, I call a little bit always these patients like the neurological strabismus patients, because we know that people with neurological problems, they often react different on surgery or on any therapy than the one who don't have it. And what I find that difficult is for these children is, for example, if you're measuring them, is to measure the angle at distance, for example. That's something I always find quite challenging. At near, you're close by, so it's more easier to measure them. But if they have to fixate at distance, then it's always, very difficult to give them attractive objects to fixate.
So I think for the audience, it's becoming obvious that there's a lot to discuss here, a lot that we may not agree on, but we're going to try and get an overall feeling of principles of dealing with these very special children. And on that note, it gives me great pleasure to invite David Granet to speak about, I do relatively less surgery, however, I use botulinum toxin. And David, just before you start, I'm getting screamed at by people from around the world. We've got now Nigeria, Chile, Jordan, Argentina, Ghana, Poland, Portugal, Sweden, Oman, Saudi Arabia, Turkey, Canada, Spain, Holland, and Azerbaijan. David, take it away.
Wow. It's all over the world, huh, Ken?
All over.
Yes. So, thank you so much for giving me the opportunity to talk about this. Paolo's already hit almost every important topic. And I'm going to straddle between surgery and Botox, which gives me the opportunity to talk about neither and both. And I think that what you've just heard from me, there's such a philosophical component to this, that we've heard that there's so many different kinds of developmental delay that Mauro wasn't able to define it. And I actually think it's very dangerous to put everybody in one definition instead of thinking of so much of this as unique individual. And not only will there be neurologic issues, there are genetic issues that may well be differences in the muscle itself. So there's so much that goes on with this that I'm going to suggest right off the bat that this is where the strabismologist and the pediatric ophthalmologist, the orthoptist, need to use every tool in their toolbox. And that breaking out your Botox or breaking out surgery for that unique individual and family sitting in front of you, and it is a family sitting in front of you, becomes so crucial. None of us ever do things alone. This is my family. And so much of what I do has been informed by my family life. This is my other family from the people I work with, also inform the work that I do. And if I can't say the word Botox without taking a moment to remember Dr. Alan Scott. Dr. Scott was one of truly the giants in pediatric ophthalmology. And when we started the listserv, which you so kindly mentioned earlier, Dr. Scott came over to me within seconds after I told him about it and said to me, never let it go. This could be the most important thing in our field. I mean, who thinks that way? And his creativity, his willingness to think outside the box, his willingness to be a scientist has just always been inspiring to me personally. When I wrote a chapter for the history chapter for Ken Wright's textbook, he was wonderful in supporting that. He's been wonderful supporting WSPOS, speaking. If you want to hear some brilliant insights, go to the webinar that he gave. And if you want to learn about Alan Scott and his attitude, this is the quote that I included in the history chapter, is that at the end, after he sold his company, he said, I'm not sure if we had all the fun and Allegan got all the money, but it was something like that. He cared about making a difference more than anything else. And our world is less for Alan Scott not being in it, and our world is better for him having been in it. So can't talk about Botox without mentioning the brilliance and the impact that Alan Scott had. This is my son, Isaiah, on his knees, talking to a child with Down syndrome in the family, who's given me permission to show this, who helped me learn a lot about what to do in these circumstances with developmentally delayed kids. My son started a program for children with developmental delay to learn how to ice skate and play ice hockey. And I learned so much. Who thought that children with developmental delay could play ice hockey? Who thought that the parents would be so touched by this? And this mom said to me with tears in her eyes, I never thought I'd see my son with a jersey on playing sports. These are families and human beings that we have to take care of and that are counting on us. This started for me early on in my career. The first report I ever did at APOS was with Rich Hurdle on children with central visual impairment and how they may look like they can't see at first, but they may develop vision later. I did a report with Gary Markowitz, Dave Schaefer, and others on the ocular findings on Williams syndrome. I was in Philadelphia and I got to meet a whole lot of children from the Overbrook School. And I'm thrilled that we have somebody talking to us, because those children taught me more than I have ever learned anywhere else. If we don't learn from our patients, we don't learn. In the United States, I think the greatest coach ever was Coach John Wooden from UCLA, coached basketball. And I love his comments. And he said, you can't live a perfect day without doing something for someone who will never be able to repay you. And this is our opportunity to live a perfect day, is when we take care of these children. The United Nations Convention of Rights for a Child and the United Nations Convention of Rights of Persons with Disabilities says governments are duty bound to provide early years services that are inclusive of and available to all children. And if you want to get me mad, the one thing you say is that somebody's not worth it. And I have heard that. I've had parents come to me and say they were told it wasn't worth doing something for their child. And that's crazy. I'm thrilled that we have somebody from Brazil who'll be talking about Botox in just a few minutes, because the Mendoza forceps that Tomas Mendoza gave to me when I visited are special and helpful in that. You'll hear more about it in a little while. I'm not going to dive deep, but I am going to talk to you about where's our evidence. Dr. Nucci talked about this. There's so little evidence that we have that gives us this information, because the information is all over the place. When do we revisit things? And if it's value-based evidence, whose values are we using? Who decides what's cost effective? What about quality of life and our personal experiences? And so Eunice, the UN said that we have a problem that children with disabilities are not involved in research as much as they should be. And we have an obligation to do so because we need to take care of these children. More so than a child who will have normal development, a child with developmental delay needs our help. We do know that in children with low and middle income countries, there is a need for action. These children often get left out, and I plead with you not to. There's an ethical drive that we have that we must help these children. The benefits are so well known, as Paolo Nucci mentioned, of the early intervention can make such a difference. When you deflect someone's trajectory early on, you change their final path where they end up in a much greater way than trying to do this later. And here you see the articles talking about the ethics of this. But let's never forget where parents get their information. Parents get their information from the public news. And there was a great study that said that on local TV news, the average medical report lasts 33 seconds. And parents hear all sorts of stories about what can be done, and that they hear words that made them lead to faith-based medicine. And we have to use evidence-based medicine, but we have to be careful not to use evidence-biased medicine, that we have to make sure our values are we use careful words when we speak to them. We have to be careful about the words cure. Parents want a miracle, so we have to be careful about breakthroughs and promises and the dramatic things that we talk about, and words like hope, which are emotionally charged, or victim. We have to be careful how we speak to our parents because these words have such emotional impact. We have to remember there are two basic issues when we deal with these children. One is, why did this happen? And the other is, can we fix it? And that leaves us somewhere between Albert Einstein and Bob the Builder. The fixing part's easy, but the thought process is hard. So let's never forget that parents are going to come to us with worries about this. And if the neurologic issue is the issue, then when you try and balance someone and you do early surgery and you get them perfectly straight, they're not going to stay there, as Paolo spoke about. If neurologically they have some fusion capability, maybe they'll stay there and maybe they'll roll off. But someone who has fusion capability, it makes our job as surgeons easy. We can just throw the ball and we get them close and they'll see. Fusion is your friend, but we don't always know who has fusion, so we have to try. Is this cosmetic? Paolo alluded to this. It's not cosmetic when you make someone's eyes straight. Cosmetic surgery is enhancing what's normal. We're reconstructing a normal appearance. And for parents and families living through this, and dare I say teachers, we've all had the experience of straightening an NLPI and being told that that child's doing better in school because the teacher thinks the kid's paying attention. It matters. It matters for bonding from an emotional standpoint. Let's never forget, this is an educational impact that we talk about and also an emotional impact. So we have to look to get services from the school and from support services. Here in San Diego, we have early infant support programs. Parents may say things to you like this.
Dr. Leader, Dr. Granet says that my daughter doesn't need surgery. Why would you ever want to expose her to all those risks?
Or maybe they'll say this.
Dr. Granet, why won't you help our daughter? Dr. Leader will.
So I took that from another talk I gave with Greg Leader, and that's where you hear his name. So the question is, how are you going to answer these parents about why you're not going to help? And what's one of their worries? Anesthesia. A child with developmental delay and neurologic issues or some of these other issues we've talked about may undergo anesthesia more often. There is a fabulous website called Smart Tots, which is a consensus statement, and that's always being updated. And it's an organization that puts together all those different groups that you see here on this slide. Let me just read this because I'm going to go over here. Should we be concerned about risk to humans from anesthesia, especially children that may be having more anesthesia than just a simple strabismus surgery? Not simple, but a strabismus surgery that may only last a half an hour. The results have been mixed, but it turns out that 2 exposures to anesthetics before age 4 may increase the likelihood of future learning disabilities. Or are we going to take kids with developmental disabilities and increase that risk? But exposure for less than 2 hours does not appear to be linked to learning difficulties. But children exposed to anesthesia for surgery and diagnostic testing before 3 years of age have a 1.7 to 1.8 times increased incidence for deficits in language and abstract reasoning at 10. There's a mixed amount of information. So on their FAQ section, they put it together and they say, research in animals and in children and some of the retrospective research we have may be helpful, but it also may cause undue concern in this patient population and family population, and may have unintended consequences that are not in the best interest of children. It doesn't mean that we shouldn't take care of these kids. We need more research. But until then, the most important thing is that children receive the surgery that they need. We are cognizant of anesthesia and we're careful about it. We always have to have careful planning. Otherwise, you end up in mistakes like this, like you see here in this picture. So Botox or surgery, you have to be the carpenter that uses the tools that make the most sense. And you must educate the parents. I will use my Yoda voice for this. Try not, do or do not. There is no try. And I think it was Yoda who said that, but it might've been Ken Nischal. They look so much alike, sometimes it's hard for me to tell the difference. But our role is to inform parents of the known facts, talk about the underlying disorder, treat that and help, get the other people this family needs involved. We are an advocate for the child and the family, and that is our job. We have to provide the teachers for what they need, and we'll hear more about that in just a few minutes. That is our job, to get involved and make a difference. This is my son when he was in the neonatal intensive care unit, holding on for dear life. Children need our help. This is what we do. And I'm going to end with this. This is Granet philosophy, and I feel so strongly about this that I wanted to put this in. No parent ever knows their child's potential. No parent knows their child's potential. It is not our job to judge a child's potential. It is only our job to help them reach their potential. That is our job, and that is our responsibility ethically. And in the end, and this cartoon from the Family Circus says that a century from today, these won't mean a thing. The house we lived in, the money we made, the clothes we wore, or the kind of car we drove. But the world would be a better place because our children were loved. And more importantly, our children with special needs and developmental delay need that love just a little bit more. And that's our job. So I hope my plea didn't go overboard here, because I just feel so strongly about this. And with that, I'll leave this to our moderators. Thank you,
David. Thank you very much. So, Marcia, that was lovely, David. We're going to have to go straight to Marcia's talk now. Marcia, thank you so much, and please start your talk.
Marcia, can you unmute, please?
Can you unmute, Marcia?
Thank you, WSPOS. Introduce you rapidly. I made my master and PhD studying strabismus in children with cerebral palsy, and I am passionate about teaching, working with children, and traveling. Here is Paolo's beautiful Italy, and my family, staying with my family, the two doctors' daughters. Well, I want to present you in one slide. I have to highlight that we do perform surgery in most cases. And here is AACD, the biggest rehabilitation center of the Latin America, where we worked. And here is the great team we work. Tomás Mendonça was the founder of the ophthalmology in the AACD. Dr. Monica made a great job with Botox, and Dr. Nilsi. We noticed improvement in the motor coordination after strabismus surgeries, improvement in the visual perception, and positive results in the social aspects that we can discuss after. Well, I do not perform surgery in these cases. This is a boy of 10 years old with a history of perinatal hypoxia, with athethoid cerebral palsy and the tetraparesis. And in the same accommodative conditions, he has a striking condition that goes to esotropia to exotropia in the same exam. So this is the disconnected strabismus. The disconnected strabismus is a pathognomonic of cerebral palsy. This is associated with athetosis, and it occurs mainly in the more severe impaired patients. So Buckley told that 30% of his patients had disconnected strabismus. In our review, we studied 290 patients, and we found 16%. Remember that the disconnected strabismus was maybe many ophthalmologists think that most of cerebral palsy children has this kind of strabismus, but it's not true, okay? I do not perform surgery in this case too. It's a 3-year-old girl with a history of prematurity, deep paralytic cerebral palsy, and she came as with an esotropia of 30, but the esotropia reduced with the time. And with 3 years old, we did the botulinum toxin in both medial rectus with the Mendonça forceps. After 10 days, the patient became exotropia. That's a very, very good result. That's what we managed. And after 1 year, the patient had a stable orthotropia. This is Dr. Mendonça and Dr. Monica work. In the small angle esotropia, like this patient, many patients tend to spontaneously progress to exotropia. Maybe this explains why the cerebral palsy children population has 2 esotropia or 1 exotropia. And instead of in the normal children population, we have 5 esotropia to 2 exotropia. So in these cases, we prefer to use the botulinum toxin because we have a less overcorrection than the surgeries. I do not perform in this third case. She's a girl of 10 years old with a hemiparesis. The face turns to the left side. Although she had a neurological problem because of prematurity, she started to face turns to the left side, and she had a -2 of abduction. And when we asked the MRI, she had a meningioma. And after the neurosurgery, the paresis went out. So we have to have here a red flag, because even in the patient with previous history of neurological problems, they could have another event that we have to pay attention, okay? This is a boy of 6 years old with a left eye exotropia, with a history of meningitis at 3 months of age. He had a derivation of hydrocephalus and a left hemiparesis. When he watched television, the face turns to the left side, and we asked a visual field that came with a left homonymous hymenopsia. So every time we have a patient with a hemiparesis, we have to remember that many of them can have a homonymous hymenopsia, and they do an exotropia to the side of hymenopsia, and they do a face turn. Why? Because the exotropia, they do to bring the nasal field to the front, and the face turns, they have to expand the visual field in front, so they turn the face. Surgery in this case, it can reduce the visual field. So this exotropia, when you have a homonymous hymenopsia, try not to operate on, because the deviation will recur. Okay, explain to the patient and parents to turn the TV or blackboard to the same side of the normal visual field as to facilitate to them to visualize. I do not prefer perform surgery in this case too. Very, very low vision. Many patients with cerebral palsy has optic atrophy, cortical vision impairment, and they use better the peripheral field because the central vision is not so good. So they use the peripheral visual field. So in this case, it's the poor fixation in center, difficult to measure the deviation. So we don't have a very good deviation or a good measurement to do the surgery. Okay, thank you for your attention. I hope you enjoyed.
Thank you, Marcia, for bringing that issue of motor coordination, visual perception, the gross motor function, scoring, and the part of visual field to this picture. Thank you so much. Because of the time factor, we will discuss all the questions at the end. We will go straight to Kyle Arnoldi. She'll be talking about orthoptist perspective on these children. Over to you, Kyle.
Okay, I'm going to forward as quickly as I can while still covering all the material. Developmental delay is a term used when progression through the predictable developmental phases slows, stops, or reverses. It may involve motor, cognitive, social, or emotional skills, but often a combination of these. And they can be due to genetic abnormalities, environmental factors, underlying medical conditions, and combinations of these. Some people like to subdivide developmental delay into categories. So we have the autism spectrum disorder group, the intellectual disabilities with IQs lower than 70, attention deficit hyperactivity disorders, learning disabilities, and finally cerebral palsy. Each category is quite different, and while it is possible for a child to have just one of these, it's very common for a child to fall into more than one of these categories. I think we do a disservice to the child if we try to, as we say, pigeonhole them into one of these categories. There seems to be a great deal of overlap, and each child should be considered separately. When it comes to the orthoptist perspective, we approach these children knowing that there's going to be limitation in cooperation, communication, and comprehension. And this is going to limit the child's ability to actively participate in the exam process. Now, we've already heard about the variability of measuring the strabismus and all of that, but this is particularly a problem for the sensory exam. Our measurements of fusion really depend on the patient's ability to communicate with us. So these issues will limit the quantity and quality of the data that we collect. We've been talking about the strabismus. Obviously, this is a webinar on surgery, but we also have to expect eye movement disorders in some of these children. Many of them have fixation instability, and this can vary from manifest nystagmus to simply the inability to make eye contact. But these children can also have impaired saccades and smooth pursuit, which makes it difficult for us to examine the patient. And of course, I advanced a little bit too quickly. Of course, no discussion by an orthoptist would be complete without referring to fusion. As we discussed with Paolo at the beginning, many of these children, though they may be operated, there is a delay to correction. And this sometimes is quite necessary. And delay to correction is going to affect the prognosis for recovery of fusion. In addition, we have cerebral visual impairment, which in and of itself will impact binocular vision. But really, binocular vision potential is not well studied in these patients. So we really don't know if the disorders we see are due simply to the fact that strabismus is more common, or if there is an independent underlying associated deficit in binocular vision pathways. Let's take a look at each of these subgroups. In autism spectrum disorders, the skill deficits fall under the social and emotional categories. The prevalence of strabismus is definitely higher than it is in the general population. But the types of strabismus are similar to what we see in age-matched normal children, with perhaps a prevalence of infantile or childhood onset esotropia. The prognosis can actually be quite good. As with many of these conditions, it's going to depend on comorbidities. Next, we have our intellectual disabilities, where the skill group involved is cognitive. The prevalence of strabismus, again, is elevated. But for this group, this number is high, 13 to 16%, likely because it's unusual for a child to have an isolated intellectual disability. These are children who have other types of developmental delays. The types of strabismus, again, the usual childhood horizontal strabismus types, and the prognosis will really depend on what else the child has in addition to the low IQ. Next, we move on to our ADHD groups. The primary skills involved are behavioral and social. Prevalence of strabismus possibly is no greater than in normal age-matched control if the ADHD is isolated. Interestingly, we don't have a lot of studies of groups of children with ADHD looking at how many of them have strabismus. We do have studies of children with strabismus to see how prevalent ADHD is. And in those situations, we find a slight but significant increase in risk. The types, again, are the childhood onset horizontal deviations with perhaps a slight greater prevalence for exodeviations, and the prognosis can be quite good if ADHD is isolated. Next, we come to our learning disabilities group, where the primary skills involved are cognitive and social. The prevalence of strabismus is no different than in age-matched controls. However, accommodative insufficiency may be found in a greater percentage of these kids than in the normal population. The types, again, your typical childhood onset strabismus, and the prognosis is good if you have an isolated learning disability. And that brings us to our special case of cerebral palsy, where the affected skills are motor skills. So it's not surprising that the prevalence of strabismus is quite high in these groups, up to 50%. The prevalence does tend to correlate well with the severity of the motor deficit, regardless of which type of CP you have. The types of strabismus, primarily infantile esotropia, but infantile exotropia is far more common in this group of children than it is in the general population. Other types of childhood onset horizontal strabismus are also common. These children are no more or less likely to have alphabetical patterns, but if they do have a pattern, they are more likely to have an A than a V. The prognosis of this group is fair to poor, but it's dependent on the type and the severity of motor deficit, which brings us to a discussion of dyskinetic strabismus. So we've already heard about some of this from Marcia. This is pathognomonic for CP. It is a comitant horizontal strabismus with extreme variability in direction, ET to XT, and angle size from exam to exam, but also within a single examination event. The variability is unrelated to the direction of gaze, fixation distance, accommodative effort, visual attention, and there's no periodicity. This is not like a cyclic strabismus. At least one study indicates that these children are prone to stabilize in their angle over time with an exodrift. This is reported in up to 30% of cases, but is associated primarily with the athetoid type of CP, which is one of the less frequently diagnosed types of CP. The prevalence will increase with the severity of motor impairment, and this is a poor prognostic sign for alignment and binocular vision. Of course, as an orthoptist, we have to discuss binocular vision just one more time before we close. So again, the question is the poor binocular vision due to the motor deficit, or is there a separate defect in the binocular vision pathways? So on the one hand, we see that we have reduced or absent stereopsis in these children, but it's associated with intermittent or manifest strabismus, just as it is in the normal population. There's a greater chance at binocular vision improvement found in milder forms of CP. So again, the connection between the severity. But we also found that non-strabismic children with CP are capable of good binocular vision. Bifoveal fusion is not common in this group, but they can be very good. In fact, what we found is that the prevalence of monofixation is higher in these children than it is in the general population. And as we've heard already, there are reports of spontaneous consecutive exotropia in children with developmental delays, which may be due to a fusion defect. So to conclude, a higher prevalence of strabismus is found in children with most types of developmental delay. With the exception of dyskinetic strabismus in CP, however, the type of strabismus is the same as that seen in children without developmental delay. Binocular vision disorders may not be the direct result of the developmental delay, but may share a common underlying cause or occur as sequela to strabismus. Restoration or improvement of binocular vision is actually a realistic goal in many of these cases. And as with all types of childhood onset strabismus, prognosis for binocular vision improves when the duration of misalignment is minimized. And this is a problem in these children because we often have to delay surgical correction. Thank you.
Thank you so much, Carl. Again, what we're going to do is we're going to go to the last speaker, Beth Ramella, who is an educator, and get her perspective, and then we'll open up for discussion. And we have lots of questions from the audience. Before Beth starts, again, I'm being screamed at because I have not mentioned UK, Colombia, Italy, Myanmar, Ukraine, and the Netherlands. Welcome, everybody, and I hope you're enjoying the webinar.
Well, hello. I am a teacher of the visually impaired and certified orientation and mobility specialist. This is my 25th year playing those roles. I'm also an early childhood and elementary ed teacher, special ed background. I have the honor of working with Dr. Nischal on a project in Pittsburgh at his hospital. And I am the CVI specialist here at Overbrook School for the Blind in Philadelphia. In addition to that, being a longtime teacher, I'm a mom. So I am the biological mother of a daughter who's in college and a son, a bonus son, who has multiple disabilities, including CVI. And we will talk briefly about both, being the teacher and the mom. Vision plays a fundamental role, we know, in the acquisition of skills such as language, motor, interpreting facial expressions, reading, writing, and hand-eye coordination. So as a teacher of the visually impaired and special ed supervisor, I have been asked to provide vision therapy by countless parents and doctors. And vision therapy, while it can focus on issues of binocularity such as strabismus or attention, there's a conflict about vision therapy in schools in that it is medically based, and teachers of the visually impaired like myself, we are not medically trained. So in the United States, teachers of the visually impaired are trained to evaluate and to provide services to IDEA eligible students with visual impairments in school settings. IDEA is the Individuals with Disabilities Education Act that ensures a free, appropriate public education for children. A child with strabismus, with or without additional disabilities, may be overlooked for an evaluation, an educational evaluation, or subsequently, they will struggle with receiving those vision services in schools, presuming that their learning disabilities are more important, more impactful than their visual impairment. A child with good acuities and also has strabismus would not qualify for vision services. Those children didn't receive services from somebody like me, from a teacher of the visually impaired. And even now, in my current work, audits of medical information in schools for blind children, sometimes these are kids who are only admitted with strabismus. But back up to what I just said, they aren't kids that receive service. So more often than not, those children also have CVI. But in 2014, OSAP, or the Office of Special Education Programs, amended the definition for visual impairments or blindness. And essentially that opened up the doors for some of our children. Children with vision issues involving stereo vision or ocular motor function can be avoidant of tasks. And so, especially when their vision is challenged, and they may struggle with depth issues that are impactful for gross motor on stairs, changing flooring, causing them to struggle with cognition problems. They may appear as though they are disobedient or have attention deficit disorders. Misdiagnosis of these learning disabilities or behavioral issues can then lead to inappropriate teaching strategies. And so we're not adapting their materials. One very simple way that we can improve their opportunities for success is by changing their learning materials. So using support such as a light box can help to encourage them to build look, reach behaviors. Those behaviors, those early practices teach them or can help them refine their vision and fine motor tasks that might lead to future things such as reading and writing. So using adaptations like the reading easel that's on the left-hand side or the adding color on the right-hand side, those things help a child organize or draw attention to their learning materials in their classroom, as does where they're sitting in their classroom. All of these very, very simple, easy strategies. Placing brightly colored tape on the edge of a step can help a mobility issue. None of these are surgical. These are all very, very simple modifications, but they're things that people don't think about. Eliminating complexity is also a big deal. So teaching children so on the left-hand side, you'll see there's a lot of visual complexity. On the right-hand side, those materials pop because there's a lot more contrast. Again, very simple elimination of complexity of backgrounds can help a child who's struggling with binocularity. Using those adaptations that are pictured can help that child not change necessarily their depth issues, but help them adapt a bit. Scavenger hunts, obstacle courses, those are things that help a child who is mobile and ambulatory, who can learn how to better maybe use their lower fields or visual scan. Again, nothing that is impossible to put into place, but things that are not always thought of first in classrooms. So as the child with strabismus begins to read longer passages in school, the print starts to get smaller, there are less or no pictures on the page for which they can derive some context. There are more words, they may begin to lose their place on the page. They're not taught really simple strategies that can eliminate some of these frustrations. The problem with academic print typically worsens as the demand increases. Calling on these kids to read aloud, for instance, it's damaging to both their competence and their confidence because they can't do it. So a teacher of the visually impaired can go into the classroom, can adapt the page with increased font, with space between words, using a line marker, using a reading stand, maybe providing some magnification for them. All of these things help them organize, help them use their vision. On the picture on the left-hand side, using a line marker, I might also, just a quick cheat for a child would be, I might use a little bit of color at the beginning, at the left and at the right. So at the beginning of the sentence, that might be green because we teach kids that green means go. And at the end, it may be red. And those are learning prompts that can be faded. We think about some low-tech strategies that can be recommended and can be supported by anybody. Moms primarily are the people that come in and tell us how to do these things. You know, they know how to best help their children. So we talked, others have talked about the psychosocial aspects of surgery. And Jackson's research argued for strabismus surgery for CP patients for psychosocial reasons, as well as for potential successful realignment and potential restoration of the binocular vision. And as a teacher, I am very, very frequently asked by parents whether or not they should continue to patch their child, whether they should use atropine drops, or whether they should follow through with surgery. These are recommendations that don't come from me. I'm not qualified to give those recommendations. But for many families, you know, they build trust with the teacher. And so as an educator, like I said, it's not my place to say whether or not a surgical option is best. However, as the guardian of a child with spastic quadriplegic CP and CVI, I opted for surgery for my son, Travis, knowing that it may need to be repeated. Knowing that binocular vision may not be restored, I needed Travis's eyes to appear to be aligned so that he would be a candidate for an eye gaze system. An eye gaze communication device would help him to be able to communicate just simple wants and needs. And in addition to his physical and intellectual disabilities, I mean, he has a host of things that make him look special, right? When his eyes crossed, people didn't recognize or realize that vision for Travis is a strength. It's absolutely a strength. And I needed that as his mom. I needed people to believe that about him. Because presumed competence is an approach that assumes people with disabilities have the ability to learn, to think, and to understand. And having been an educator for as long as I've been, I feared that by not trying to correct Travis's strabismus, that he would not be presumed competent. Partnerships like the one that we are doing today, being included as an educator on a panel like this one, these are continued learning opportunities between medical and educational communities that greatly benefit families and children. And that I am incredibly passionate about. I can never say enough about the students that I work with and how much I've learned from them over the years, far, far more than I have ever taught. Thank you so much. I am humbled and honored to have been a part of this panel, and I appreciate your time.
Well, I firstly, thank you very much, Beth, for what really is something that we don't hear enough of. And thank you for the poignant sharing of the story of your son. And I know how lucky he is to have you as his mom. Okay, we are going to go into full-fledged discussion mode now, and there are lots of questions coming up. I'm going to kick off with one question. I'm going to throw it to Mauro and Daisy to then ask the other panelists. So the question is, has the panel seen change of esotropia to exotropia in children with developmental delay spontaneously? I have a child like this. What could be the reason for this?
I take the microphone.
Yep, go ahead, Mauro.
No, this is Paolo.
Okay.
Okay, no. Go ahead, Mauro. Go ahead, Mauro.
Okay, I've seen this happen. Probably this was what I think was Kyle that said, and Marcia. Probably the neurological aspect of the child that doesn't bring any type of fusion. So this can happen. And this is exactly one of the reasons for planning a child with esotropia for an undercorrection, because we know that they can go spontaneously to a exotropia.
Yeah, me too. I've seen it.
It depends, Mauro. It depends. As I told you, my experience with Down syndrome it's quite forgiving. You can correct as they normally do, and there's a lot of literature about this. Down syndrome patients should be treated in the same way. Why? While I have the same worries in cerebral palsy children. I have not much experience, but for example, athetoid children, they usually start with an exotropia, and you try to operate them and they go back to exotropia at the beginning. So there is a lot of difference. But just to say my impression, what is amazing is that none of us can add a discussion on this huge topic. We did not share a single word. And surprisingly, everybody presented an identical way to see and approach this group of patients. So it's really amazing. I'm so glad to have confirmed what I was thinking and what I was doing. And this is really is amazing. All over the world, people with the same experience.
I wanted, Ramesh, jump in anytime you like, but I want to go to Marcia and Kyle. Marcia, you brought up something that I think is really important. You brought up imaging and the MRI and how the role of that MRI may help you decide what you're dealing with in terms of fusion. And I really want to open this to Marcia, David, and Kyle. How many times do you look at an MRI or ask the pediatrician, is this athetoid CP, to help you understand if this is dyskinetic strabismus? Do we do that? Marcia, you clearly do.
Yeah. Yes, the MRI doesn't help us to tell if it is an athetoid or a spastic one, or even if it's going to be so severe, because MRI images doesn't happen to, how can I say, to concomitant with the clinical exam, neurological exam. So, but there is a paper talking about the MRI and the overcorrections. They tell that in the MRI, when you have an MRI more severe impaired or more severe, you have more overcorrections, mainly in the esotropia. But I thought that the MRI, but I will have to do the MRI. Most of them do, even in the start, but I don't think it's going to tell you if it's going to have a more important severe athetoid or spastic one.
David, Kyle, do you look at the MRIs?
Ken, if I'll jump in, Kyle, if you don't mind first. When I was a fellow at Children's Hospital in Philadelphia, where I first met all these wonderful teachers for the visually impaired from Overbrook, the thing that we noticed was that we had children who had flat VEPs and a year later had developed significant and normal vision. And the single thing that separated them was they had a normal MRI. And so this goes to what Paolo was talking about, is waiting for the development of vision and some of the changes that make place. So many of our decisions are based upon neurotypical kids and how they develop. But we're looking at children now who may have not just developmental delay, but a different developmental series of milestones. And when we intervene, may be different because of that. So we do look at the MRI specifically for this, so that we can bet on the child instead of betting against the child. I think you go broke when you bet against children. And I just have to thank Beth for what she talked about and the emphasis she put on. We are all partners in taking care of these kids. And if we're not listening to the parents, we're making huge mistakes. And we're not learning as much as we could. So Beth, thank you for all that you talked about today.
Kyle?
No, I would say I look at the MRIs less now than I did 10, 15 years ago, because I agree with what David said. Don't bet against the child. So what I found was the athetoid CP supposedly is associated with MRI deficits in the basal ganglia and cerebellum. sometimes what I have found is that we look at the scan and it looks bad. A clinical picture doesn't necessarily match with what we see in neuroimaging. So that's my answer, really. I don't look at them as often as I used to. And I really go more by the clinical picture, and that includes not just the eye exam, but the posture of the child and how the child's interacting with me and all sorts of other factors like this.
May I add something about the explanation for this? This is the answer that comes from the redundance that there is in the brain. So we have other area that organize the movement except putamen or globus pallidus and all these things. So we had possibly in this group of children other areas that starts to behave in a correct way. So I think the redundance helps us a lot.
Although I think that's so important, what you just said. It's why I don't say to parents, your child will never fill in the blank, right? Because we don't know that. We don't know if they're going to recover. We don't know how they're going to change. We don't know what parts of their brain are going to go to. And I try and stay open to saying, we'll see.
Yeah, I just wanted to ask one question related to this. I think we have a group of patients where do nothing in terms of strabismus management, and of course, take care of refractive errors. There is a group specifically do botulinum toxin and wait for that temporary improvement in visual perception as well as coordination. I think Beth brought up a very important issue that they should be competent, or at least this part is very important. And then strabismus surgery, or with all the risks involved. There is one question, this probably Mauro and Paolo can answer. What's the experience with regards to long-term undercorrection of esotropia and exotropia? Do you think it's different in esotropia versus exotropia? And we all kind of agree that we have to undercorrect them. If you take them up for surgery, don't go for the full angle. Do you see any difference? Mauro, you can go first.
I do see more overcorrection when you operate on esotropias than in exotropia that goes to esotropia. Those are, in my small experience, but they are quite rare. But so that's why you have to undercorrect the esotropic patients.
Daisy, Paolo, go ahead.
Okay, no, Daisy, please, Daisy.
Daisy, I just wanted to see, you will be seeing this on a follow-up, right? Do you think more of this, there is a difference between esotropia and exotropia, the outcomes?
I don't know. I haven't studied it. So just out of my mind, I really can't answer that, no.
All right, let's go to Paolo.
Ramesh, that overcorrection with exotropia is quite uncommon. I'm always worried about the possibility of a worsening of esotropia that goes too well. Except I said with Down syndrome, they behave normally. There are children like Williams. Do you operate them? And they are perfect. They have possibly the same experience. He followed a lot of this. They are perfect and with time, they goes to exotropia. And this happens very often. I don't think that there is really the possibility to undercorrect to prevent. It's something that you cannot measure. And sometimes they goes smoothly to overcorrection. And actually, the parents are quite happy also with this exo deviation, especially in Williams, and maybe also in the fetal alcohol syndrome. They are a little bit more like the attention deficit and hyperkinetic disorders. So I think this is really a spectrum, but with a lot of roads going everywhere.
Ramesh, I'd like to just do something.
Yeah, go ahead.
Look, I think, Marcia, you brought up a really important point. I had a patient 2 years ago, had 3 surgeries for exotropia, but nobody had realized the child had a homonymous hemianopia. Every time you operated on that child, that child's brain went, I don't like this. I want to have that extra field. And I think the assessment, that's why I talk about the MRI and the assessment to make sure that you are not going to make this child's adaptive behavior come back again. And I think that's really important. Let me ask you all a question. My understand this, all of what I'm about to say to you has come because I did a lot of work with craniofacial children. At puberty, when the interpupillary distance increases, any propensity for an exotropia gets worse, any esotropia gets better. And I think that if you look at these children who get this sort of, they go from an ESO to a big XT that Paolo was mentioning, we have not done a correlation of what happens when that interpupillary distance changes at puberty. And so my aim in these kids is to use Botox, get them to puberty, let them have their growth, and then fix surgically whatever strabismus you have left. What do you all think about that?
And this works with the Cruzone or Apperts?
No. I'm talking about these two.
I was just kidding, Ken.
Yeah, I think Ken, it's a very, very good idea. We do this. Esotropia of 20, 25, we do every time this Botox. The Botox is of 3 to 5 units in each medial rectus. And after 25, 30 prisms of diopters, yes, we operate on. But if you have 30 prism diopters, we plan a surgery about 20. Okay. The same occurs when you have an exotropia. When you have an exotropia, you have to plan a bigger surgery, okay? Because we have a lot of undercorrection in the exotropic patient. So if you have a 40 prisms, you do a surgery for 50, okay? So I agree with Dr. Ken. We prefer to do the Botox and to have a nicer and better results.
So look, on that point, we just go around. There's a question about the dosing. Does your dosing for surgery change in children with cerebral palsy? But let's open it up. Does it change at all for these different children? Because Paolo, I love your, have you published that table? That's a really nice table that you had for those specific syndromes. Let's just go around. Ramesh, does your dosing change? Does it change with Botox? Does it change surgically?
Always, I try to undercorrect them, both mostly esotropias. Exotropias probably kind of keep them at the straight thing. But somebody was saying that we cannot check the visual field in the children, especially in their infants and toddlers when they have a problem. Probably we need to kind of extrapolate by looking at their MRI. I think MRI has a specific role in deciding what you do for these children. I think at least one MRI we need to have it. And as Ken said, some of the children will have a very subtle delay. Here also, unless you are careful, you may take them as a typical infantile esotropia and operate. And these are the patients will come back again and again, whatever you do with the exotropia. So one answer, I would undercorrect up to 15 to 20% in these children. And I have seen the significant improvement in motor coordination and visual perception in children with esotropia, not so much with exotropia.
David?
That's my take.
David?
Yeah, so I changed my goal, but I'm never sure exactly how to change my dosage. The different children respond so differently. I have a goal of what I'm trying to do. I do try to uncorrect, but the dosage I find much less predictable. And we're talking about such a disparate group of children that it's hard to make a statement for all of them in all these different categories. So I struggle every time. I do know it's important. And in terms of examining a child, I think these are the children you have to examine multiple times before you take them to the operating room to understand what the visual system is doing. And I frankly rely on our teachers for the visually impaired who are going to the child's home and the parents to talk to me about what the child's doing, because what do we spend? 5 minutes, 10 minutes, 15 minutes with that child? I want to hear what's going on elsewhere so I can put together an entire picture of the child, make an individual plan, and worry that I didn't get it right, because the dose response curve, as Paolo alluded to, is just different. But my goal does change in terms of what I'm trying to achieve.
So Paolo, you're agreeing. I'm going to go to Mauro. Mauro, do you change your dosing?
Yes, I do. Usually, at least here in Brazil, we follow the guidelines, the group from Marcia and Tomás Mendonça that has the larger experience in our country. So what Marcia said is what we perform.
Marcia, Paolo, do you want to add before I go to the...
No, I just agree with Dave. It's the dose response is a problem. So I concur with Dave and Steve Archer that saying to do 0.5 millimeters less doesn't mean anything for me. You have to follow the child, as Dave said. This is not something that you can resolve with rules. There are no rules, no golden rules.
So, Marcia, would you agree? Would you already? Yeah, you've already agreed with us, right? With the group as a whole. Okay, so let's ask the orthoptists.
Okay.
Well, okay, Kyle, no, go on.
You want? I was going to say that. So this is not a comment specifically on dosing, but it's related. So I always tell my patients, these are neurotypical patients, the younger you are, when you develop strabismus, the more likely it is that you're going to need at least one other procedure at some point in your life. So I use that same template, basically, and when I'm speaking to the parents of developmentally delayed children, I think that one of the important things that we have to make the parents understand, this is not going to be a one and done, that they should expect that there will be a second procedure. Now, maybe that's going to be in 6 months, but maybe it'll be in 6 years. So I think if we set up appropriate expectations at the beginning, and then again, dosing, I think you have to take each case individually and look at the whole picture and see what you get, but prepare them ahead of time. Our study that we published in 2006, what we found was that 2/3 of these children, and these were all CP cases, 2/3 of them will have a really good outcome with an average 2 surgeries. So, and then the remaining third either just didn't do well or needed more than 2. So I share with them that statistic so they have something to shoot for. And this way, the variability that we see, the variable response, they're not surprised. Surprises for the parents, that's never good. Daisy,
So, Daisy?
Well, I think it's important to when you speak to the parents that you explain that you cannot predict the outcome, and our experience is that it's often not what you want to have, and I think that's important that patients know that they may not hope that perhaps what the end after the operation it will be less than they expected, and I think that's very important. But I do agree that it's important that we operate these children. It's not because they have mentally delayed that they have to be crossed eyes for the rest of their life. So I think you have to treat them as a normal strabismus person, but I think you have to explain the patient that because of their delay, that the outcome of the operation will be less predictable than with the let's say normal children. Even with these, it's not almost predictable.
So we're going to go 5 minutes over. Carl, we're going to go 5 minutes over. I just want to go to Beth. Beth, if you have a child who you have been educating and they had a strabismus and they have surgery and they come to you, do you see a change in their ability to respond to your teaching methods?
Yes, I do, but I also see it. I always have a high expectation of improvement for students, but in their other team members, in their other therapists, in their teachers, in their general ed or their special education teachers, that's where I see a more impactful expectation for improvement. And they have no necessarily, they don't know that they aren't equipped, with maybe the exception of the OT, to make those learning accommodations for whether or not they're using binocular vision. But they expect the child to do better because they look better.
Fantastic. So look, we could be talking for another hour. We don't have that time. It's been amazing. Can I summarize a little bit? Then I'm going to invite Mauro to.
Maybe Mauro. Yes, Mauro.
Yeah, I'd like Mauro to say a few words, and then Ramesh, if you can sign out for us, if that's okay. I'll put the slides on. So look, I'm getting the impression, listening to everybody, that when I see a child with delay, whether it's motor delay, cognitive delay, whether it's a combination, I should be communicating with the educator to see what they see at school, what they're seeing. I should make sure that I know from the pediatrician, has this child got hypotonia? Is this spastic diplegia that I'm seeing? I should look at the variability of the position of the eyes. I should look at the MRI before I decide and formulate a plan. Are we all in agreement that that's the kind of protocol that we should all have when we see these children? Okay, I'm now going to ask Mauro to say a few words, and in the meantime, I'll start sharing the screen. Mauro, thank you for what you're about to say.
Thank you, Ken. I have to say that I learned a lot in the past hour and a half. We have been discussing the golden numbers and Botox expectations, the global development of and improvement, predictability, variable angles, and reoperations. But I would like to say and thank Beth for her words and the statement about her son. And I want to pick two words from David's talk, which is child's potential. Some of you know that I have an autistic daughter. She has strabismus and amblyopia that I treated her due to anisometropia. And I want to make a personal statement here. I think that it's easier to treat the patient and it's more difficult to treat the family. We have to remember that we have a family behind the child. My daughter was told, we were told when she was 2 months of age that she was not going to read, to speak, and to walk. And I want to say that she just wrote a book showing how we all are imperfect. So I want to just remember that, of course, all the technical discussion we had here, it's very important, but do not forget to share your love with the family. This makes the difference. Thank you.
That's fantastic, Mauro. Thank you so much for that message. It's very, very important.
Ramesh?
Okay, with that, I think we should close this. It's a fantastic discussion. And obviously, you will have more questions. Please email them to admin@wspos.org. We will have them responded to by all the panelists as well as moderators and speakers, and we will email them to you. Next slide, please. We have upcoming webinars, one on managing glaucoma in patients with anterior segment dysgenesis on 19th February 2022, that's next month. And in commemoration of World's Down Syndrome Day, again, we spoke a little bit about Down syndrome today. We are going to talk about the holistic approach for the ocular problems in children with Down syndrome. To have it on Saturday, we will have it on the 19th, not on the 21st. I hope all of you will join, and you will tell your pediatricians and the friends to join this. Join us on WSPOS. The membership is free to any one of you who are taking care of children. And also join our Facebook page and the group. We discuss a lot of cases there. And as I said before, Dr. David Granet is, having that listserv. Please email to him if you want to become a the member of that, so that we can discuss these difficult cases across experts from the world. And membership benefits, Ken has already alluded to. Please, there are multiple benefits of becoming members. And also, I was just talking to one of my fellows. There are 43 webinars so far. This is the 44th. They are available for any one of you to watch. And also for each of this webinar, along with the 90 minutes video session, all of these questions are answered on the PDF file. So it's a big kind of knowledge bank for all of you. Thank you all so much, all the audience across the world who have joined. We would like to thank all the speakers, moderators, and discussants. Mauro, thank you so much. Beth, thank you so much for that personal message. That's what we should remember. Thank you so much. And always, Todd International, who host our webinar platform. Thank you so much always. And also, I would like to extend my thanks to WSPOS admins who always work with all the speakers and experts and delegates. Thank you so much. Have a good evening, good afternoon, and good night. See you all soon on February 19th for glaucoma. Thank you.
Thank you so much.
Namaste.
Have a wonderful day.
Stay safe.
Thank you, everybody.
Thank you very much.
Thank you very much. Beth.
Thank you.
Thank you.
Can I